Now, for today, we are joined by Robyn, Dr. Robyn Thomson. She graduated from Glasgow University, where we crossed after during the rotating internship for a brief period of time. And I think initially, Robyn, you wanted to go into surgery, not anesthesia, right?
Yeah.
And then you changed your mind about it
Mhm.
and moved to anesthesia. You did your residency at Langford, got your diploma in veterinary anesthesia. Now you are working at Ralph. Good thing I just asked this to double check. But also, I hope you'll talk to everyone a little bit about your new project regarding anesthesia in the profession and vets getting vets to talk about anesthesia and not just delegating anesthesia to everyone else. And I think that's going to be really, really important. And that's going to be part of the topic today. So I'm very happy to be able to pass it a baton. I hope that's how we say it in English, and
Yeah.
make sure that you can now deliver a very good presentation and also tell us a bit more about your project because I'm also looking forward to hear more about it.
Thank you so much. Right. Let me just get my presentation up. Okay. So thanks for that really lovely introduction. Yeah, so my name's Robyn, and I am a specialist in anaesthesia here in the UK. As Andrea said, my whole plan in life had actually started out that I was definitely going to become a surgeon. It was absolutely my goal in life. Until I got out into general practice and realized that the part I really liked about surgery was actually the anesthesia side of things. Um, so once I'd sort of realized this, my goals changed, and I very much started going in the direction of anaesthesia residencies, which I did in 2017. I finished in 2020, and then I became a specialist in anaesthesia. I now work, I'm still working in the UK. I work at the Ralph, and my whole vision in life, I guess, and what I would love to see happening throughout the veterinary community is that we see vets taking a much more interest in anesthesia. I think there's been a huge amount of time has been spent making sure that we have nurses that are fantastic at doing anesthesia, and I work with some fantastic anesthetic nurses. But sometimes I think that we, as vets, and I definitely noticed when I was in practice, kind of take a step back in that role and kind of lose where we fit in that. So my aim, I guess, throughout my career is going to hopefully be that I want to really educate vets, make sure that they actually have the confidence in anesthesia that they can have, show them how to work well with their supporting staff, whether that is here in the UK, which will primarily be with veterinary nurses, or whether that is throughout Europe or the States, depending on where you are and what support staff you have there. I think it's so important that we remember that as vets, we do have a very important role. And I really, really want to educate vets and make sure that they actually do see that. So that is hopefully going to be the start of the plan this evening, is that I'm going to sit and discuss a bit about the role of vet in anaesthesia and then show you what you hopefully can do as a vet. So as I've already said, I qualified in the UK and I practice in the UK. So most of my experience comes from the UK. And therefore, the little bits about the legal side of things are going to be a bit more UK heavy, because that's where I work. That's what I work within, and it's where I'm more comfortable. But I think the underlying principles are the same no matter where you practice. The idea being that the role that a vet has, I think, is the same no matter where you practice. So the two things I really, really hope you do take out of this evening is understanding where you as a vet do fit in to the anesthesia, and then show you and hopefully how to formulate and how to use your role in the form of formulating comprehensive anesthetic plans, because really that is a huge part of our role, and hopefully through the tonight we'll get to that and you'll see how it all sort of fits together. So now I think my slides are a little bit slower than me talking, sadly. So hopefully
It's not changed yet. Now it did.
there is fabulous. Perfect. So a little bit of the legal stuff to start with, because once we get that sort of out the way, then we can talk about the bit more of the bit that I think is a bit more fun anyway. So in the UK, anaesthesia must be carried out by a veterinary surgeon registered with the Royal College of Veterinary Surgeons. Obviously, depending on what country you're in, you'll have your own professional bodies, but that's the professional body that we work with in the UK. And therefore they are the governing body for us as vets. Within that, what the Royal College has said and what our code of conduct said is that the veterinary surgeon may then delegate the task of maintaining and monitoring anaesthesia to a suitably trained person. Now, they're really specific about what a suitably trained person means, but generally speaking, that is going to be a veterinary nurse or a student veterinary nurse under supervision. And you've got to have evidence and practice of that training. But very specifically, when it comes down to the actual act of performing an anaesthetic, the legal responsibility and is that of the veterinary surgeon, not of the veterinary nurse, not the veterinary student. It is our legal responsibility. So veterinary nurses, I said, and student veterinary nurses may be directed to assist veterinary surgeons with the maintenance of anaesthesia and monitoring of patients under anaesthesia. So they can do all the bits and bobs of monitoring, helping maintain that anaesthetic. So things like adjusting vaporizer settings under direction from the vet themselves, instrumenting patients, so obviously placing the IV catheters, some local blocks as well. There's lots of things that nurses can do, but very, very specifically, it is under the direction of the veterinary surgeon. So the following advice, so the Royal College has set out quite specific what they do and don't want people doing. So things like induction of anaesthesia. So that can be done by a veterinary nurse or a student veterinary nurse under supervision by the administration of specific quantities of medicine. So nurses and student veterinary nurses, can't administer to effect. That is something that only us as a vet can do. And that's because the nurses themselves have their own code of conduct. And within their own code of conduct, one of the things that they can't do is prescribe. And administering a drug to effect would then be actually prescribing that drug. So that very specific induction to effect is very much something that only a vet can do. Then maintaining the anaesthesia, it's the responsibility of the veterinary surgeon, but that suitably trained person, so our veterinary nurse or student veterinary nurse, or similar depending on what country you're in, may then assist by acting as the veterinary surgeon's hands. So they can do the things like adjusting the vaporizer settings, giving the medication, but it is still the responsibility of the vet to prescribe those drugs. So making sure that we say, for example, if we're asking one of our support staff to give a dose of an opioid, for example, we should be giving that dose, not just saying, yeah, just give them whatever. It's very, very specific. And then obviously the Royal College has gone into not just the immediate monitoring of the anaesthetic, but the recovery period as well. That is also under the responsibility of the veterinary surgeon. Again, it can be carried out by a suitably trained person, but again, at the end of the day, it is our responsibility still. So what does that mean for us? So it's really, really easy for us to get caught up in the nuance that's sort of been, a lot of the time, anaesthesia is seen to be the nurse's job and they do most of it and they're the best placed person to do it and all this kind of thing. And therefore vets seem to take a little bit of a setback in that. But in the eyes of the Royal College, it is very much our responsibility. And while we absolutely cannot do our jobs with our veterinary nurses, because gosh, they are fantastic and They have a wealth of knowledge and experience behind them. At the end of the day, the legal responsibilities lies with us as vets. Therefore, we can't be ignorant to the process. And it doesn't matter if we agree or disagree with the Royal College and the Code of Conduct at a personal level or a professional level right now. This is what our framework that we must work within. And therefore, as vets, we absolutely must ensure that we are taking responsibility and that we are taking an active role in the anaesthetic process itself. And while this is obviously what comes from the UK legislation, it's going to be quite similar no matter where you go. At the end of the day, we are vets and we are the ones that are legally responsible for these patients. And therefore, we shouldn't be putting all of the onus onto our nursing staff that we work with. And we should be making sure that they are not being asked to work out with their code of conduct, and make sure that they're also we are providing them with the support and the respect that they deserve. So how do we do that? There we go. So, as I've already said, we all know that nurses are absolutely vital to the provision of anaesthesia, particularly here in the UK. We absolutely could not do what we do without them, but vets are ultimately responsible. And as such, we should be aiming to ensure that all vets have a really solid understanding of anaesthesia and are competent. This will allow them to appropriately support all the staff that are involved and ensure that the patients absolutely get the care that they need. And it's really important here that we therefore have a symbiotic relationship between the nurse and the vet. Both of us have to have a good understanding of anaesthesia and be confident in our abilities so that we can work to complement each other rather than working against each other. This means that we can provide the best care for our patients, make sure that we're making sure our patients are safe, as well as working within both code of conducts. Now, my ideal, which probably in the UK is never going to be practical, but this would be my ideal, is that every practice within the UK would have a vet that is dedicated to the provision of anaesthesia. So that even if it is our nurses that are doing the majority of the maintenance and monitoring, looking after these patients into the recovery period, they have a vet who is responsible for that patient's anaesthetic that isn't the person doing the surgery. Because let's face it, in the UK, a lot of the time, vets are required to oversee their own anaesthetics while performing the procedure. And I therefore love it that there would be that additional vet, that separate vet that is able to provide that support, provide that care for that patient so that someone is focusing on the anaesthesia and that vet who's doing the surgery doesn't have to worry about that aspect, because that is a really stressful thing to have to do, being able to do two different jobs at once. That's why when you're looking at referral level, we have a separate team of people that do that. We have the people that are doing the anaesthetics and we have people that are doing the surgery themselves. And it's probably not practical. It's something I'd love to work towards. It's what my aim in life will be, is that we do try and get towards that here in the UK. And I'm hoping that it is starting to get that way, but I think we've got a bit of a way to go. So this really does therefore mean that the relationship with the nurse monitoring the anaesthetic and the vet's own understanding of what they are doing is so important. So we need to make sure that, first of all, our team members, so vets, nurses, everyone involved, is competent, that they have a good base level of knowledge there, but that they can also communicate effectively between each other. Because you can have all the knowledge in the world, but if you can't communicate with each other, you're not going to be able to provide that best care for the patient. Now, these are topics that I could talk for hours on, and I absolutely would. But we don't have that time tonight. We have 45 minutes. So we're not going to do that. So instead, what we're going to do is we're going to focus on what we can do, what we can start right here, right now, hopefully sending you away with something that you will be able to build on. Okay. So how do we build vets that are confident and competent in anaesthesia? So having a good understanding of anatomy, physiology, pharmacology, and equipment will massively help with this. It goes without saying, these are the core foundations of anaesthesia, and the stronger these are, the easier things become. However, as I said, we don't have time for all of that tonight. These are whole courses in themselves. But what I am going to show you is how to make an anaesthetic plan that gives the anaesthetic nurse a sound working base and gives you, hopefully, some brain space. So an anaesthetic plan is absolutely not just what drugs you're going to give to your patient, because that's actually the easy part and when you get through the process. It's absolutely everything from the pre-anaesthetic assessment throughout the recovery period and beyond. So by having that solid plan before starting any anaesthetic, it means that you've thought through all the things that could happen and made a plan. And it means that the anaesthetic nurse, if they're the one monitoring, has a pre-discussed course of action should certain things occur, so that they are able to have a little bit of ability to act while you're maybe doing, if you're the one also doing the surgery, while you're potentially at a really nitty-gritty important moment. So as I said already, in here in the UK, nurses cannot prescribe under the code of conduct. That's very much got to be something that a vet does. And as I said, if you're at a really, really difficult part of the surgery, and then you've got someone else asking you, I need a dose of medication, what am I going to give them? I need to give it now. You're risking patient safety here. We're risking things going wrong. We're going to potentially give a wrong drug dose. We're going to do the calculations wrong. We're just adding a layer of complication that isn't needed. So by pre-planning, we can then eliminate a lot of that and simplify the process. Because if you've already discussed as part of your plan that if X happens, do Y, then all that needs to happen when that is then happening under the anaesthetic, the person monitoring can say, hey, X, this is happening. Are you happy I do this? The conversation can be, yes, absolutely, proceed. So at the end of the day, our role to know as a vet, our role is to know what's happening, when it's happening, and help manage that situation. And because the patients are our responsibility and we want to reduce risk to these patients as much as we can. And that is therefore so much easier if you've already thought about it before you even start the process. And the way that we think about the process is this is how I do it. So while every patient is unique, they are someone's loved one. There's no getting away from that. I always ask my team to think of each patient as very much this unique individual that there will never be another one of. However, there is also some aspect of actually a lot of the things that are going to happen are going to be very similar between each anaesthetic. And when we start thinking about this, and when we start thinking about these patients, their procedures, what conditions they have, what we actually end up having is a very long list of considerations that actually for each condition are the same, or for each procedure are very similar. And these considerations, which I'm going to go into more depth to sort of explain a little bit more, will all have a possible consequence, which then we can make a plan for. So while these patients are absolutely unique, the things that can happen and the things that we have to think about aren't entirely unique. They are going to happen, or there's a chance that they will happen. There's a chance for each patient that's got the same condition, these things could happen. So for you as a vet, if you're the one supervising and you're already thinking about all of these considerations, you can plan for them. You can put a plan in place with the person that is going to be monitoring. If it's you that's monitoring, even better. You've then pre-thought about all this, and you're hopefully going to have a much easier ride when you do the anaesthetic. But the aim is here, by thinking about these considerations, you are going to improve your patient safety and you're going to improve your staff well-being. Because if you are organized and you've thought about things beforehand, you're not asking your staff to run around like headless chickens, trying to work things out, trying to get things when we could have had it all organised beforehand. And this is something that I do with every single one of my team. And they probably will hate me for it when I start, because I get them to stop usually halfway mid-sentence because they've started like, I'm going to give these drugs to this patient. And I'm like, nope, let's go back. We're going to start with our considerations. And most of them will probably roll their eyes at me the first few times, but then they slowly do realize actually how important this is and how actually it makes things so much easier. So what you will start to see is when you start thinking about your considerations and when we broke them down, is that you're going to build up lists, really long lists that then kind of fit together like puzzles so that you can then put together. And this formulates this beautiful anesthetic plan that takes everything into consideration. So when we think of these, we can split them into 4 distinct groups. So our first one are our anesthetic specific considerations. And these are considerations relating to the provision of the anesthesia specifically. And then we've got our patient-specific considerations, condition-specific, and procedure-specific. And what I'm going to do now is I'm going to go through each of these, hopefully relatively quickly, focusing a bit more on the anesthetic-related ones because they are the thing that you are going to see every day and give us that a nice flow, hopefully, to show you how we fit this into our planning of our day. Or planning for anesthetics, sorry. All right. Okay, so the first group of considerations are our anesthetic considerations. And these are the things that can happen during any anesthetic, as they are the result of the anesthetic itself. So they can happen to any patient, regardless of procedure or condition or procedure that you are doing. And there's 3 of them. And they are hypotension, hypothermia, and hypoventilation. And what you will see is we're going to use each of these to show you how, thinking about the consideration, the possible consequences, and then having a plan, you will be able to factor this into your day-to-day anesthetic planning. Okay, so the first one we're going to start with is hypotension. So hypotension can occur due to the direct effects of the drugs we use to induce and maintain anesthesia. Now, what I'm thinking about here is not a specific patient or a specific condition or a specific procedure. This is just thinking about what an anesthetic can do to our patient. So I'm being really generalized here, very specifically, because there are so many different drugs you can use, and we don't have time to do each individual one. But generally speaking, most of the drugs we're going to use to induce or maintain anesthesia will cause vasodilation, blunt our cardiovascular reflexes, some more than others, and can cause reduced contractility. Some of them are going to cause bradycardia. But all of these are going to contribute to the development of hypotension. And we can therefore plan for this. So we know we're administering an anesthetic. We know that, therefore, we are to consider that we're going to get hypotension. So the consequence of hypertension, obviously, we know is reduced organ perfusion and potentially end organ damage. There's lots of different things that can happen for that. So let's plan how we're going to manage a hypotension should it occur. So the first thing we think about is how we can max spare. So reducing our anesthetic, reducing the amount of drug that we need to keep our patient anaesthetized. And usually this means by using a multimodal approach and not just relying on a single drug. It means utilizing local anesthetics where we can. So we already know this is a potential consideration. We know that this is something that we can plan for. So we're going to use a multimodal approach. We're going to use as much other drugs as we can, therefore minimize the amount of drug that we need to maintain anesthesia. And then if it does happen, we know, because we've thought about this beforehand, that vasodilation, reduced heart rate, and reduced contractility could all be contributing to this. So we can pre-plan what we think we might need to give in the event this happens. So the exact plan that you come up with will obviously be dependent on the other considerations. So when we're taking the patient as a whole, but there's a general idea of this is what I would kind of be thinking about doing. So in my plan, I'd be saying, okay, the first thing I'm going to do is see if I can max spare any more. So can I give any additional analgesics, usually an opioid or ketamine under the anesthetic? And then what I'll do is go, right, what's my heart rate doing? If I have a low heart rate, I'm going to have pre-thought that I'm most likely going to give something like glycopyrrolate. So I can have that dose pre-calculated so that I can say to my nurse monitor the anesthetic, this is how much I would like you to give if the heart rate drops below this. If I think vasodilation is the thing that's causing the biggest problem, I can have that pre-authorized dose of ephedrine, for example, to give. And if it's reduced contractility we're thinking about, I can be thinking things like dopamine or dobutamine. And can have all these, as I said, already calculated for when, if and when the hypotension does occur. Then what's not happening is it happens, it's pretty profound, everyone's getting a little bit stressed, and we're all trying to work out what we're going to give, when we're going to give it, and all getting a little bit higgledy-piggledy with things. Okay, so then hypothermia. So this occurs usually because we alter the brain's ability to thermoregulate. So we change our thermoregulatory set point, and then we don't have any behavioral components to then help with thermoregulation. Our anesthetic drugs then lead to vasodilation, which causes a loss of that core to peripheral temperature gradient. So we get rapid heat loss. It goes through conduction, convection, radiation, heat goes. And it's usually within that first 30 to 60 minutes of the anesthetic that we get that biggest drop in temperature. We know that's going to happen. It's not a surprise when a patient becomes hypothermic. We know they're going to become hypothermic. So the consequences of this would be altered drugs pharmacokinetics. We can have organ dysfunction if we get really cold. We get dysregulation of many normal processes, and it's really unpleasant for the patient if they are then conscious. So in the recovery period, really, really unpleasant. So we know it can happen. We know that it can have pretty profound consequences. So let's plan for it. Let's factor this into our anesthetic plan. So we can pre-warm our patients where it's appropriate. So if they've already got a low body temperature in the pre-anesthetic exam, we can pre-warm them. Or in those ones that are really high risk for heat loss, so like your tiny puppies and kittens, or the ones that are hairless, the animals that are got very little fat covering, we can pre-plan, we can pre-organize pre-warming them. And then we can make sure that our active warming is present and ready to go from the start, not from halfway through the anesthetic where the patient's already hypothermic, from the start of anesthetic. And because we know that's when the biggest heat loss is going to happen. So let's have it there ready to go. We already factor that into our anesthetic plan because we're thinking about it. And then we've got hypoventilation. So this is our final anesthetic specific consideration. And we know it's going to happen because our anesthetic drugs act centrally, causing respiratory depression, leading to hypoventilation. Consequences of that are potentially going to be hypercapnia, with or without hypoxemia. Again, that's slightly dependent on how severe it is and other patient factors as well. But we can plan for it. We can have a plan ready in advance if we know that this is something that's going to happen. So we can max spare again, because if we can reduce the drugs that we're relying on to maintain an anesthetic as much as we can, then what we can see from that is hopefully they'll ventilate a little bit better, and therefore then we won't need to mechanically ventilate. But if it doesn't happen, we can plan that mechanical ventilation is something we might need. So you can already have had that chat with the person monitoring the anesthetic about what strategy you're going to use before you even start. And more importantly, if you don't have a ventilator and you know that this is a patient that is high risk for hyperventilation, because when we go through the rest of them, you'll see, because it also pops up in their patient-specific considerations, their condition-specific and their procedure-specific ones. When we see that it's a really high risk for hyperventilation and we don't have a ventilator, then we can think, right, well, do I maybe need an extra set of hands so that the person monitoring the anesthetic doesn't also have to be the one continually ventilating this patient? So we can have pre-discussed that. We can have have it in place, we can know who's going to do what and when they're going to do it. And that means if you are the one that's then doing surgery, it just needs to be, hi, this is what's happening. Happy for us to go as planned? Yes, rather than having to come up with a solution while you're midst doing something else. So once we've gone through our anaesthetic specific considerations, which are as I said, they're the ones that are going to happen to every patient because they just are the thing that happens when you anaesthetize a patient. We then get to the ones that are slightly more individualized. So we first of all have our patient-specific considerations. And these are related mostly to things that you can't change about a patient. So they are the things like species, breed, age, gender, and temperament. They are that patient in the absence of everything else. So if they were fit and healthy, these things would still be them. And they really do massively impact our anaesthetic. And I'm going to use very quickly, because I know we don't have much time, I'm going to use age to show you how that when we plan for that. And I'm going to use our lovely little neonates because neonates are one I always get questioned on. So I thought I would use them as a quick example. So if I was thinking about a neonate, so my patient that's coming to me to be anaesthetized is really young, let's say a 6-week-old kitten, or 5-6-week-old kitten. We do quite a few of these. One of the first things I would be thinking about is a cardiovascular system. So right straight off, that's going to be my first consideration. So they have less contractile tissue per gram of myocardium compared to an adult. So that means their cardiac output is far more dependent on heart rate compared to an adult. The consequence of this would then be, therefore, if the patient becomes bradycardic, they are far more likely to become hypertensive. So in our plan, we make sure we take that into account. So we want to try and avoid drugs that are going to cause bradycardia, or at least reduce the doses of them that we're using. And if bradycardia is present, then we're going to treat it. And the most likely drug I'm going to treat it with is an anticholinergic, which I can have my drug dose pre-calculated. And then if we think about our little neonates, they have got a much higher water content compared to adults. So I really I'm not interested, I think it's quite funny, but I like think of my little young animals as little grapes and my old geriatric patients as raisins. So my little neonates have much higher water content. My older animals have a much lower water content. And that's just part of the normal aging physiology. We're not talking about dehydration or anything here. We're just talking about the normal total water content of these little animals. But because these are got slightly higher water content compared to their adult counterparts, things like our volume of distribution of drugs are going to be a little bit affected. So we have to take that into account. So how are our drug doses going to be affected? Obviously, that's going to be specific to each individual drug, but generally speaking, I'm going to start thinking about my pharmacology. I'm then also going to be thinking that these little guys are therefore going to be more susceptible to fluid losses because fluid losses. So the consequence of that is potentially going to be hypotension. I can plan for both of these in my anaesthetic. So if I know that I'm going to get altered pharmacokinetics, I can think about how I'm going to adjust my drug doses. Again, it depends specifically on which drug you decide to use, but you know you're going to have to think about it. And if I'm thinking that, well, I'm getting increased susceptibility to fluid losses, I'm going to make sure that I'm not going to prolong fast these guys. Again, these guys aren't going to be fasted for a long time anyway, because if they're depending on what they're eating, where they're at on their weaning process, you're probably not going to starve them for very long anyway. But I'm very much going to make sure that the fluids aren't withheld. And if we do have fluid losses, I'm going to replace them. So this isn't an exhaustive list. This is just 2 considerations from the neonate. But it does show us how we can start factoring everything in to our anaesthetic plan and be proactive rather than reactive. Because what we want to do as vets is we want to proactively make sure that we've thought about these things and have our plan in place for when, and I'm not going to say if, for when things go wrong, because there is a high likelihood that they will. Okay, so once I've thought about our patient in the absence of any specific considerations, disease processes, we then actually start thinking about any conditions that they have. And this is probably the biggest section of all. because a single patient can have multiple different conditions, all with their own specific lists. So this is my own cat. This was when she had her shunt surgery. So she had an intrahepatic shunt, or was an extrahepatic, sorry. But she also has feline asthma, just to complicate things. So then we also get the cats that have got hyperthyroidism and chronic kidney disease, or the dog who has diabetes mellitus, who then goes out and experiences trauma and gets a fractured pelvis. Each of these conditions will have their own specific list of considerations that you then sort of combine together and plan for, basically. And a patient can have one comorbidity, they can have 3 comorbidities, it doesn't matter, but you can think of each of these in sort of their individual, as an individual, and then combine them together. And you basically get a big long list of things that you think about and plan for. So if we use our example of diabetes mellitus, so a consideration for diabetes mellitus is hyperglycemia. And the consequence of this would potentially be osmotic diuresis. So we're potentially going to get dehydration and reduced circulation volume, especially if they're then fasted. And then that can potentially lead to hypotension. So we can already factor this into our plan by making sure that we first assess hydration status prior to GA, ask their family about the patient's current thirst levels, get a good idea of what they are actually like at home. Then we might need to think about correcting any losses prior to the anaesthetic themselves. And then making sure we have appropriate fluid therapy for that patient during the anaesthetic. So I've already planned for that. I know that this is potentially going to happen, so I'm going to plan for that in my anaesthetic. Second consideration is on the flip side, you can also get hypoglycemia for these patients. The consequence of this is going to be things like weakness, lethargy, seizures, so on. And we can plan for this by monitoring our glucose regularly throughout the procedure. Typically, I usually monitor every 30 to 60 minutes, depending on the patient. But then we also can have our glucose dose calculated, and we can have it worked out of how we're going to make up our bag of 2.5 or 5% glucose, so that if it happens, no one is having to try and work out this calculation in an already stressful moment, because no one likes working out how to make up a bag of 5% glucose if you haven't done it in 6 months. So if we pre-plan for that and we already know what we're going to do, we're reducing everyone's mental workload and we're improving our patient safety, because we're not adding in an extra step when we're already in a stressful moment. And then we get our procedure-specific considerations. So these are the things that are entirely related to the procedure. So you kind of forget about the patient as an individual and you just think, what is this procedure going to do to my patient? And for the majority of the procedures that we perform, the first big consideration is going to be nociception. So anything surgical, nociception. Because nociception is the anaesthetist and the patient's worst enemy. It has a whole host of consequences, including sympathetic stimulation, activation of the stress response. But if we know it's going to happen, we can predict the points, at which is most likely going to occur. Then we can plan for this. So an example here would be in an ovarian hysterectomy. If you're doing a little bit of pulling on that ovary, that tends to cause a huge amount of nociception and stimulation to that patient, which can then negatively impact your plane of anaesthetic and make it, which is obviously not ideal for the patient. They're going to be experiencing nociception, which we don't want, but it's also going to make the surgery more challenging for the surgeon. So if you've got a patient that's now puffing and panting, makes it a little bit more difficult for them to do the surgery. So what we can then do is we can have thought about this. We know, right, traction on the ovary might cause nociception. I'm going to plan for that. And one of the options that you can do, one of my favorites, is having a little bit of ketamine ready to go. So you can pre-plan that and you can say to that individual that is monitoring, whether that's you, your anaesthetic nurse, whoever that might be, right, if X happens, you can give this. And it means then if you are trying to ligate the pedicle, the patient starts reacting, there can be that line of communication, which is patient's reacting, heart rate's gone up by this, blood pressure's gone up, respirate's gone up. Can I give the ketamine? Yes. It becomes a much simpler process of rather than trying to then work out what can I give, how much am I going to give? It's just a back and forth, yes, no. No one's trying to run around, no one's trying to work out drug doses. We're not risking our patients suddenly jumping off the table, having awareness. We're just proactively managing the situation. And for other procedure-specific things we're going to think about, we're going to be things like the positioning of the patient. So will they be in dorsal recumbency? Because that consequence of this is increased risk of hyperventilation. So as I've already said, we can then think about how are we going to manage that? How are we going to manage that? Is the head going to be away from the person monitoring the anaesthetic or towards them? Because if the head's away, monitoring the depth of anaesthesia is a bit more challenging. So we can't monitor things like jaw tone, palpebral reflexes. So we can factor that into the plan. For example, I know that if I've got patients that are having surgery within the mouth or on their eyes, and I know that I cannot have access to their head at all, I will be far more vigilant in ensuring before I start that I'm happy with my plan of anaesthesia. I very much have backup plans. I use probably I'm more likely to use CRIs in these procedures because I'm very aware that lighted plane of anaesthesia isn't just bad for the patient, could be also risky for my surgeon as well. And it's not as easy for me to get to that patient and do what I need to do. So I factor that in already. I'm thinking about that. And then we're going to be thinking about what is the surgeon actually doing, because surgeons with hands and abdomens, they're going to be pressing on blood vessels, which can lead to hypotension. They're potentially going to press on the diaphragm, which can potentially lead to hypoventilation. So we can start thinking about all of these things and have a plan in place then for when they happen. And one of the big ones obviously is going to be as well is what are we then doing in that surgery? So are we going to be ligating very large vessels? Is there a big risk of hemorrhage with this patient? Because if the answer is yes, then we can pre-plan for that. So do we need to think about blood typing? Do we need to think about making sure we actually have blood in the hospital? And obviously, if we think blood's a big risk, let's have 2 intravenous catheters placed before we start. So that if you are then having to give a blood transfusion under the anaesthetic, or you're having to put in a lot of fluid, you have the IV access to do that, rather than trying to faff around under the drapes, placing a second IV catheter when that liver lobectomy does decide to bleed. And because you've already pre-thought about it, there's no stress. We're like, great, it's happening. We've got a plan in place. We can just do this. Okay, so I hear you. How practical is this? It sounds super time consuming. It sounds like something that is just going to take up a big part of your day and maybe doesn't have that much reward. So I'm going to be honest, it probably to start with takes a little bit longer, but actually it's not as time consuming as you think. So I do get all of my team to do this, and the first few that they do will probably take, as I said, a bit longer, but generally speaking, for most patients, this is going to take 5-10 minutes. Because what you'll start seeing is an OVH, so ovarian hysterectomy, has a list of considerations for itself, and those procedure considerations are the same regardless of what patient you're operating on. You then just got to think about the specific patient and if they have any comorbidities, but the considerations for a patient with diabetes are the considerations for a patient with diabetes if they're having an ovarian hysterectomy or if they're having a cataract surgery, because their disease process doesn't change. So you start seeing that you get really good at knowing what is going to happen for these different things and then putting the puzzle pieces together to become your overall patient plan. And yes, for your complex patients, it will take much longer. But those are the patients that absolutely need that level of consideration put in for them. And because they're going to be the complex ones, they're going to be the ones that are going to have more complications. So by putting this effort in, you will absolutely have it pay off, because you're not going to be stressed trying to work out what to do when something happens, because you've already thought about it and you've made at least the first part of that plan. Yes, there are going to be things that might arise that you've not thought about, or that your initial plan doesn't do what you want it to do, but at least you've got that initial plan and it gives you the headspace to hopefully start thinking clearly and organized thought processing to then, right, okay, that's not worked. What's my next step? And as you get through all this and as you start doing this more, you'll have already thought about the next steps before into your plan. So I can be doing, as part of my job, I don't sit and do a single anaesthetic. I monitor, or I supervise multiple nurses doing who are monitoring the anaesthetics. And by doing this with them, I then already have got in my head what I'm going to do, and I've already discussed it with them. So when then I come because something isn't going quite right, because I'm checking on them, I'm going back in, I'm going between them, and they're already right. This is what's happened. This is where we're at. This is what we're thinking about now. I'm like, great. Have you got all that ready? Yes, I've already done it. It makes it a much more efficient process. It makes it therefore for your patients, it's much safer. It's reducing risk as much as we can, because by being organized, by being pre-prepared, we will hopefully be able to give a much smoother process and do the best things we can for our patients. Now, I was going to go through an example, but I'm realizing what time it is.
It's okay. I think everyone will be quite happy to hear that.
Yeah. So will we go through it or not go through it?
Go through it, yes, for
Go
sure.
through
I
it.
think
Absolutely.
everyone
Cool.
is,
Sorry.
yeah, I think everyone will be quite curious about this bit.
Cool. So if I was to get this as a patient that comes in, so we've got an adult French Bulldog dystocia. So I'm going to go through the general idea here of what I would do, because obviously I'm not going into a very, very specific patient here. But if I was thinking C-section, French Bulldog, coming in for dystocia. So the first big things that I'm thinking, an adult, otherwise healthy adult before this, lovely dog, had been fine, but I've just got some big puppies stuck in there. So the first things I'm going to be starting to think about for this patient are to do with her breed. So patient-specific things here first. So she's a brachycephalic. She's going to have increased risk of airway obstruction, increased risk of difficult intubation, increased risk of regurgitation, and she's got protruding eyes, which are therefore at increased risk of damage. Okay, so my consequences of this, hyperventilation, hypoxemia, aspiration, which then can also lead to hyperventilation and hypoxemia and respiratory fatigue. So my consequences here of what is going on here, I've already thought about this. So how am I going to plan for that into my anaesthetic? Well, I'm going to have suction available. So if she does regurgitate, I can manage that situation very, very rapidly and hopefully reduce my risk of aspiration. I didn't write here, but I'm going to do a head-up induction if I can, because again, that's going to hopefully reduce my risk of regurgitation. If she does regurgitate, I'm going to drop her head. I'm going to have a selection of smaller ET tubes available so that if I have a difficult intubation, I will hopefully then still, if I go smaller, I'm still hopefully going to be able to get that. But I'm also going to have a backup intubation plan. So getting an ET tube in is never my only intubation plan. So I'm going to be thinking things like urinary catheters to at least be able to get oxygen in, to provide oxygen during that difficult intubation. I'm going to be thinking, does this dog, is there any other way I can intubate this dog? Again, going to slightly depend on what you have in your practice, but you're going to have that thought process there. But I'm also going to think not just for induction, but for the recovery period as well. Because she's a brachycephalic, I know that not just the induction could be a problem, recovery could be a problem as well. If she regurgitates, I'm going to be thinking about gastroprotectants. And again, depending on what you have available, depending on what you use. And I'm going to make sure that I lubricate those eyes very, very, very well. And I'm going to protect those eyeballs because I don't really fancy having to re-anesthetize this dog in a few weeks to have a corneal graft for a perforated eye ulcer because I didn't lubricate the eyes well and protect them during the procedure now. So that's very quickly. That's what I would generally be starting to think about for my patients. So I'm going to have ready my suction, my small ET tubes, I'm going to have my drug dosage worked out roughly what I want for my gastroprotectants, and I'm going to have a lot of eye lube and probably some eye covers for this patient. I'm then going to think about, I'm 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 then going to think about the condition itself. So pregnancy has effects on the body that massively affect physiology of the mum, and therefore we have to take that into consideration. So cardiovascular system. Generally speaking, we get a slightly increased cardiac output for these dogs because we've increased our blood volume, and because obviously we're supplying a very, very gravid uterus at this point in time, but we've also got blood vessels being more relaxed because of the hormonal changes, and we have a decreased sensitivity to catecholamines. So all of those things together are going to mean that hypotension is more likely to occur. Hypotension is really bad for mum, but it's also really bad for the neonates. So we're going to affect puppy, hypotension is potentially going to affect puppy viability, and it is going to obviously affect mum and her recovery. So really, we absolutely want to avoid or at least manage hypotension very rapidly. So I'm going to monitor her blood pressure closely. So if I've got time, I would put, place places an arterial catheter, but that's because I'm confident in doing them. I can do them quickly, and I don't add anaesthetic time getting one of these to place one of these. If I can't do that, I'm just going to make sure that I have a form of blood pressure monitoring, whether that's Doppler or oscillometric, it doesn't matter. Just make sure you are doing it and you are treating what you see. So have your drug doses pre-calculated, have your fluid therapy ready and waiting to go, have it on, and obviously throughout the procedure and administer fluids as and when needed. And obviously, as I said, treating the hypertension. So the respiratory system. So we get an increased minute volume through increased respiratory rate, but we have also got a decreased functional residual capacity. So your functional residual capacity is the bit of lung that at the end of a normal expiration is still left inflated. So it's kind of our buffer for when we don't breathe. That means that we still are oxygenated. But in these dogs, it's much smaller. Actually, not just dogs. In any pregnant individual, the functional residual capacity is reduced. We've also got an increased risk of atelectasis, because we've got a very big abdomen that is going to be pushing up on our chest, and the gravid uterus is going to splint our diaphragm, which basically means it makes it more difficult to move. So hypoventilation is very, very likely to occur, and hypoxemia is more likely to occur because of our reduced functional residual capacity, especially when we have apnea. So what am I going to do? I'm going to make sure that I pre-oxygenate if I can before I induce this patient. Obviously, if she's incredibly stressed getting and not going to allow us to do that, I'd rather we didn't. But in those patients that are going to allow it, absolutely do. We're going to make sure that if we can, we're going to monitor for the hypoxemia during the induction process and make sure that if we can't do it while we're inducing, we get that SpO2 probe on very, very quickly post-induction to see what our oxygenation is. And we're going to make sure we've discussed how we're going to provide respiratory support. And that's going to depend on what you have available to you. For me, that's going to be mechanical. That's going to be a ventilator. If you're in practice and it's you and someone else doing the anaesthetic, it might be, can we get another set of hands in to give us a hand, if we need to have a person be the ventilator. Then we think about the central nervous system. So this is also my condition specific considerations. This is how pregnancy is affecting my patient themselves. So the blood-brain barrier permeability is increased, and I'm going to get some CNS depression because of the progestogen that is there. So I'm going to have increased sensitivity to some of my drugs. So we might need to use lower drug doses and titrate to effect where possible. Your max, your minimum alveolar concentration, is also going to be a bit lower. So make sure you're adjusting your vaporizer setting based on what you actually see is happening to your patient. Don't just set it and leave it. And you want to monitor your depth closely because things can change quite rapidly. Then we've got the gastrointestinal tract. So our stomach is going to be more squashed and more cranial because, gravid uterus is going to push everything up towards the thoracic cavity. We've got slower gastric emptying, and we're going to have potentially reduced cardiac sphincter tone. So this means we've got an increased risk of regurgitation, which is something we've already noted because she's a French bulldog. So I've got a really big increased risk of regurgitation in this patient. So I'm going to make sure I have my suction available. I'm going to have my head up induction, and I'm going to make sure that I inflate my AT tube cuff before I put my head down, so that if the content starts spilling out, hopefully my airway is then going to be protected. And we have to think about our lovely gravid uterus itself. So the gravid uterus is going to do compression of the vessels within the abdomen, especially when you then move into dorsal recumbency. So we're going to reduce venous return to the heart, which is going to reduce our preload, going to reduce our cardiac output, and it's then going to lead to hypotension. So we're going to think about that and how can we plan for that happening? Okay, so I'm going to think about positioning. So when I position my patient, I'm going to try and tilt her slightly to the left when she's in dorsal, so that she's slightly off of her abdominal, of her vessels, off of her vessels, mainly, the vena cava. So I'm hopefully going to impact venous return as little as I can. And I'm going to think about if I have to move recumbency, I'm not going to do it rapidly. I'm going to do it slowly. So I'm not just going to go with my patient. I'm going to do it slowly because we'll tolerate better slower movements than we will do fast movements. And then we're going to think about the placenta. So we have to think about the placenta because the placenta is very important at this stage. It's what is keeping the neonates or the babies alive. Anything we forgive mum can go to babies. So because most drugs are going to be able to cross the placenta. So this means you have to think about what drugs you're going to give. So my plan of action is going to be make sure that I use drugs that have antagonists, because then I can give the antagonists to the neonates if I need to. And I'm going to use drugs that are short acting, and I'm going to use drugs that hopefully are not going to have huge effects on the neonates themselves. There are many different trains of thoughts of what drugs you actually should use, when you should use them. All I'm going to say on this one is, because obviously this would be a slightly more in-depth conversation normally, is mum deserves analgesia no matter what, because, as we said before, surgical procedure causes nociception. Nociception activates your sympathetic nervous system, it activates the stress response, which has negative consequences for the mum. And will also, if she is in pain post-operatively, because when she's unconscious, it becomes pain, she is then going to be less likely to allow her pups to feed. So mums have analgesia. The analgesia that you are going to give is going to depend completely on what you have available to you. Local for me is really important, even if that is a line block. I think that they're very good. They can be very effective, and they're definitely going to be something that you can definitely utilize in this patient. And then we think about the procedure itself. Basically, we're thinking this one, as I said already, nociception is going to be our biggest thing. And most of the other considerations I've pretty much already said here. We're going to be in dorsal recumbency. So that means we're going to be increased risk of hyperventilation. So I'm going to plan for probably going to need to mechanically ventilate this patient. Our surgeon is going to be in our abdomen. We are going to potentially increase the risk of vessel compression, splinting the diaphragm, so hypotension, hyperventilation. We've got a risk of hemorrhage with this patient because uteruses have a huge blood supply in pregnancy because we're feeding that placenta. So hemorrhage is a very, very big risk. So double IV, potentially blood typing this patient if she's blood type naive. If she is blood type naive, that you maybe don't need to do that. Then you can think about, do you have the bloods available? If not, what fluid therapy are you going to use? And we then know, or the biggest thing then we have to think about this procedure as well is lift the uterus out. That is the time when we're most likely to get hypotension. We can have pre-discussed that. We can pre-discuss how we're going to manage that hypotension at that point in time, which is usually going to be through a fluid bolus. And then we need to think about, do we need to have some estrogen or adrenaline CRI there ready to go if it is severe and doesn't respond to fluid therapy. So we can have all of that in place, in plan, and that didn't take, obviously I've went through that, and that's obviously something that I've pre-thought about, but it doesn't take a huge amount of time to think about it. And you can already start getting all those bits ready for it. And while yes, I absolutely get all my team to do this, that's my nurses, my interns, my residents, I still do this every procedure that I have. I don't go obviously talk through it quite like I've talked through it like this, but it's going through my head while I'm doing it. Because I know as a vet, that patient is my responsibility. That patient is someone's loved one. I want to do the best things I can for them. So whether I am the one that is directly monitoring the anaesthetic myself or I'm supervising someone else doing it, I make sure that I know my patient, I know what can go wrong, and I can have a plan of action in place for if it does go wrong. Because I don't want to be chasing my tail. I want to be proactively managing the situation. Because that's our responsibility as a vet. That is where we fit into this picture, is we are there to make sure that patient has a safe anaesthetic, to make sure that they come out the other side in the best possible way they can. And as vets, even if the Royal College didn't say, if they didn't explicitly say, even if our professional bodies were like a bit more ambiguous and didn't have that in it, they are our patients and they are our responsibility. And we therefore need to know what we're doing. We need to understand why we're doing what we're doing so that when things go wrong, we know how to manage them, we know what to do for our patients, and we can support the staff that are the ones they're monitoring. Because at the end of the day, if we don't have that understanding, we don't have that belief in what we're doing and that we can make a difference for these patients, then we're really not doing the best that we can for them. So I hope that's been helpful. I appreciate it's a very whistle-stop tour. If anyone does want to ever actually go through specific patients, it is my long-term plan is to basically come up with a Bible of this. It's just a very, very, very long-term plan. And I love talking about these things. I love talking about anaesthesia as a general, but how we can be proactive in anaesthesia and how we as vets can fit into anaesthesia again, rather than just passing it off and being like, it's someone else's job, not mine. Yeah, thanks.
Wonderful. Thank you so very much, Robyn. It's very, very good. I think we don't have a lot of questions, but I have some things that I want to discuss,
Yeah,
if that's okay.
absolutely.
Um, what I'm going to do is for people who want to go or they need to leave. I want to make sure that you guys have your 1CPD app code ready for you. For those of you who are in the UK, I think you can see it now. So you can basically use it to log your CPD right now, and that's it done, and you don't have to think about it later on. You can reflect on it already, and be done with it, and be ready for your 40 hours. If you are not in the UK, you can get a certificate of attendance. Send us an email to info@univetsglobal.com. It will still work the other way, but it's easier for you to just remember this one. So if anyone wants to have a certificate instead, because you don't work in the UK and you don't need the to log this on the app, then you can get in touch with us. We will take a little bit of time. We are running a course next week. So we will be slower. We'll be full hands on deck on top of this week where we already have a course going. As you can tell, I'm still not 100% up for this challenge. Guys, if you need anything else, Robyn also left her contact. I'm sure she will be happy to answer more questions about anesthesia for anyone that is
All the
interested.
questions.
So what I wanted to do is first I wanted to go through a couple of, well, not questions, but one thing that I was thinking about was when you were discussing uh, the foundations of anesthesia, you also talked about equipment. And I find this is one of the most challenging parts of anesthesia because everyone is like, what drugs can I use? When can I use? What do they do? And no one tells you, this is what the machine looks like. This is where you plug things in. This is how you use a ventilator. And I find it really hard to find that type of information. How do you get to that? Because everything that I see has 5 modules on everything else and 1 module on some of these.
Yeah.
Where do you find this information?
So there isn't somewhere that's just simple like this is the one-stop place for anesthesia. So one of the best textbooks out there for kind of foundation, like getting to know your stuff, is probably the BSAVA manual, Veterinary Anesthesia and Analgesia, which I have somewhere in the book collection is over there. It doesn't give you everything, but it gives you a good starting point. But I agree. Basically, everyone focuses so much on what drugs we can use, we kind of forget about, a lot of people forget about everything else that goes around it. It's something that I'm actually working towards. So there is, I have a whole group of presentations on how capnography works and how that then impacts how you use that for your patient, how the pulse oximeter works, and how that impacts your patient. So it is out there. Well, it's not out there yet. It's something that's there. But if you're wanting a relatively decent textbook of what will kind of go through that, that's kind of where I would go is the BSAVA manual. Everything else, so you've got, because I've seen that there's one about textbooks and stuff. There's things like the Bible, the one that we have to use for one of the ones we use for our specialist exams is Lum & Jones, but that is very in-depth, over-the-top textbook for everyday life, to be perfectly honest. So yeah, the BSAB manual would tend to where I go. The other option is that I tend to use is Dugdale's Anaesthesia. I think she's called Veterinary Anaesthesia, and author's Dugdale. That's generally quite a good textbook as well, because they break it down quite simply, which is what we want, because the equipment is so important. And if you understand how your equipment works, but also understand why it maybe doesn't work or what it doesn't do,
Yeah.
it makes your life a lot easier.
Yeah, exactly. Good. I think you might need to later on send me the names of those books. I mean,
Yeah,
obviously I got the BSAV manual, but the other ones, because this is
yeah,
one of the questions we are asked as well,
absolutely.
was books that you think
Yeah,
are
I can
relevant.
send a list of them.
We don't
But
need, maybe three,
I'll send three.
maybe
I'll
three,
send you
I
the ones.
hope.
There's there's so many, but yeah, I'll send you the ones that I think for everyone general practice getting
Yeah.
started in their anesthesia journey, I'll send you the ones. It would probably be the BSAV, Dugdale's, and they'd probably be the main two actually.
Hmm. Okay, two is good as well, because we can get those two. I know we were talking a lot about anesthesia. We were talking about general anesthesias, but I really like the framework that you used because what you did, in my perspective, was to focus on the foundations that you need to have for every procedure. And then if you don't have that, it just feels like you have bits of information and you're putting them together. It's like, oh, buprenorphine takes longer to act than methadone, so I'm not going to use that one. So, but you're not putting it all together. So I really like the perspective of this big picture.
Yeah.
Can we apply something very similar to this to sedations as well? They're
Yeah.
shorter, but
Yeah.
obviously they're not necessarily shorter.
No,
But
definitely not. So I do this. So I'd say general anesthetics, obviously, what I deal with,
yeah,
but we do this for all of our stations as well. I probably don't
okay.
go into it as in depth with them. I It's generally not quite as much, but absolutely, if we're doing something with the patient, we should be having these thought processes, and it's just a really good habit. It doesn't matter what the patient, it's a very good habit because the more you do it, the easier it becomes, and because that sedation might turn into a GA at some
Yeah,
point because that's
yeah,
what usually happens. For a lot of time that's what happens for me anyway. So it's always good to have that thought processing already there, and you'll see that it actually gives people a lot more confident in ownership of that procedure, that sedation, that journalist, that you have a lot more case ownership, which I think is quite a nice thing to have as well.
Yeah. And following this up, because I thought this was so nice. I know you probably kind of do this in your head all the time with every single case you
Mm.
have, because this is the thought process for the job that you're doing on a very common, pretty much daily basis. But is there like a written model, or like do you have like a patient sheet where you have this area for your conditions and this for the rest, and then you do all of this like you do like a monitoring anesthesia sheet?
Yeah, so we
Okay.
have a very small section on our anesthetic sheet, and we kind of have more of a tick box just for them because
Hmm.
we would not have enough room for our patients to actually do that. But it is something that is actually really easy to combine in with your anesthetic monitoring charts. And actually, I have one that I've kind of generated to kind of include it with it because it's a very good learning tool as well for all the people involved, and especially if you work with students as well, which obviously we do. It's very, very useful for them as well, and obviously it's great for the patients as well. So it's quite easy to combine it into your anesthetic sheet, and I think I have an example of somewhere.
Yeah, because I figured, I was just thinking about this, like it's not something that we would do with this detail. But I'm thinking it is probably very easy to adjust our anesthesia
Yep.
monitoring charts, our anesthetic charts, to add something like this and prepare everything before the patient is
Yeah.
actually being worked on.
Yep.
Um, and that's what I was thinking, because now you have all the checklists available as well for all these sorts of different things.
Yep.
It doesn't feel like it should be a checklist, but it
It
can turn into a checklist quite easily.
Yeah, which you don't want it to become a checklist too much because then because it's slightly more than that, but it is so easy to have it as part of it. So I think the biggest example is we have so when you go through this, you'll see that when you combine everything together, you get things that are really likely to happen. So if they
Yeah.
appear in every section, hypotension, then we know that's highly likely to. So we have a tick box where we say that is a higher than likely to happen.
Yeah.
We would tick that, and then on the reverse, so ours are a double-sided drug plan sheet is what I call it. We have on the back we have our interventions. So
Yeah.
if like what our fluid therapy plan is, any pre-prescribed drugs that we're going to be giving, we have them already written down,
Hmm.
which is quite useful. So it's
Yeah.
quite easy to do.
Yeah. Now this question is coming because you talked about a C-section,
Hmm.
and this is in specific related to the procedure itself. And the question is about the most important steps to minimize risk of aspiration, pneumonia, and airway complications in animals in general.
Yeah. So for me, the biggest thing for regurgitation is knowing knowing when it's going to happen and then what to do when it happens. So for these patients, any patient that is at risk of regurgitation, I always get us to do any induction in sternal recumbency, so as sternal as you can have, until with head up. And as long as there is no regurgitation happening at that point, you keep the head up. So for the induction process, until you're intubated and your endotracheal tube cuff is inflated. At that point, you can then bring the head down. There are things that you can do. So for some patients, you can potentially place things like nasogastric tubes beforehand, and while they're conscious, obviously not while they're conscious, because obviously that means you can pre-empty the stomach in some of these patients. But for some patients, that's too stressful, and stress isn't good because we don't want stress in these patients because that's just going to make everything more complicated. So if it's something you can do, absolutely, you can pre-place an nasogastric tube, empty the stomach, or remove some of the fluid from the stomach at least. But otherwise, the biggest thing is going to be keeping them in sternal, keeping their head up until they're intubated and that airway is secure. Once that's happened, once the cuff is inflated, we can then let the head down. Now, if during the induction process, the patient starts to regurgitate and you can see it coming up, if your head is up, and you've started giving medication, they will not have the ability to protect their airway at that point. So at that point, if your head is up, gravity no longer becomes your friend because everything is just going to go down your larynx into trachea. So you need to, at that point, tip their head down and let as much of it come away as you can, because gravity then is working with you to empty everything away from the larynx. Obviously, while this is happening, you absolutely need someone monitoring your patients. So you need someone with hands-on pulses, someone watching the breathing, because you can't get an endotracheal tube in at this point. If you've started giving that induction aid and this happens, you're kind of in this weird place of, I need to intubate them, but I can't intubate them because if I try to do that at this point in time, they're probably just going to aspirate. So that's why it's really important to have that suction ready to go, because if it starts happening, you can tip, start to suction, get as much of it away as possible, get them back, rapidly intubate them, and then proceed to then managing the situation, which is going to depend a lot on the individual specific patient, but it's going to be a lot of potentially a lot of suctioning, flushing out, maybe putting some sodium bicarb down, depending on the patient. I tend to just lavage them, gastroprotectants, again, that's depending on what you have available to you. But my typical one, if I'm doing it, would be omeprazole. I would give them meropetent. Meropetent is not going to stop them regurgitating, absolutely not, but it is going to make them feel a lot better because it's going to reduce nausea in the post-operative period. So it's not going to help the regurg, but it's going to make them feel better, which I think is really important. You're thinking about metoclopramide, but obviously you just got to make sure it's not contraindicated depending what else is going on with the patient. But very much suction as soon as you've got a secure airway, suction as much as you can, empty the stomach if you can. Yeah, that's a really important thing. And make sure you recheck before you start the recovery process, because although you could have done all this at the beginning, everything looks great, it might have had a silent reflux under the anaesthetic. You might have something sitting in the esophagus. Just check again before you start the recovery process.
In line with this, I think you've answered it, but just to make sure the answer is correct, giving antiemetics before anesthesia is not going to help with regurgitation.
So antiemetics, no. So they're going to help vomiting. So regurgitation is a passive process. There are some papers out there that there are drug protocols that you can use that may reduce the risk of regurgitation. So, and so I've got to get it right because it's been a long time since I've read it. But I think it's cisapride and metoclopramide combination is the one that is most likely to reduce the risk of regurgitation. But it's high doses throughout the perioperative period, and there's risk of side effects with them, and it doesn't stop it, it just reduces it. Antiemetics are antiemetics, they stop you vomiting, which isn't the same as regurgitation. However, anesthesia itself can cause nausea and can cause vomiting. So I would still give them antiemetics, because most of my patients, unless again it's contraindicated, get an antiemetic, because post-operative nausea and vomiting is horrible. Nausea, anesthetic relief nausea, it's not a nice situation. There's a lot of evidence things like meropetent actually might have a bit of a max sparing effect. So if it's not going to cause harm, then I absolutely would just use them.
Yeah, wonderful. And last question, pharmacology question for you, of course.
Love pharmacology.
Right, of course, now we've done the C-section, and now what do we use for analgesia for the mum? Because now she's going to feed the puppies. So basically is what would we consider as options for post-op analgesia for a C-section?
So it's going to depend on what you have. And I'm not going to say there's a right answer here, because different anesthetists will absolutely give you a different answer. So I would be making sure that mum has some form of local during the procedure, whether that is before incision or after the incision, depending on how quick you've got to be. I always try and do something before. And that would be depends on the patient. So I'm happy doing epidurals, but obviously that's me myself. But in practice, I'd be recommending things like a line block, or if you can do things like tap blocks, and so transverse abdominis plane block, it's ultrasound guided. Obviously, don't try it the first time when you're doing a C-section. Definitely not the place to practice. But it's something that if you know how to do, you can do in this procedure. So local would be my very, very with bupivacaine because if you've got because bupivacaine or ropivacaine are long acting, so it's going to give us analgesia into the recovery periods, which obviously is great. We want that. We like that for the mum. I will give opioids. So I'm not going to say I don't. I do give opioids. I will probably give her a one-off dose of an opioid. Again, what opioid that is going to depend on what you've got. I have methadone, so I'll use methadone, but I'll probably use a low dose. And then I will give more if I need to. So if mum is uncomfortable, I can then top up. I'm not going to just give her a big, big dose. I'm going to give her a little dose and then I'm going to top up if need be. I will, as part of my pre-medication, I potentially, depending on mum pretending situation, I again will probably use fentanyl, but fentanyl short acting. And by the time we've done everything we need to do and we get to theatre, it's probably not having an effect. I'm using it from induction, which is just to make things a little bit easier, reduce the amount of induction agent I need to use. But then for that recovery, yes, I will probably give something like methadone. If you don't have methadone, that's fine. Morphine is another option. If it's one, obviously in the UK, it is not licensed, just because I have to say that. But I know elsewhere it is something that people do have access to. Then there's a question of NSAIDs, which I don't think you're going to get a right or wrong answer here. If mum is cardiovascularly stable, and that's my big thing here, if mum is cardiovascularly stable and she's not had any vomiting, she's not got diarrhea, she's been normotensive throughout, I will probably give her non-steroidal. But I'm making sure that mum's okay here. Yes, there is potential that they go in the milk. There's the question of what that could do puppy. But then there's also the question of mum's just had, or the big thing of mum's just had a massive abdominal procedure. So, and if she doesn't want to feed her puppies, that's also not great. So you kind of swings and roundabouts here. Otherwise, I tend to give them paracetamol. So I will use a lot of paracetamol. IV, orally, both of them. It's great. Absolutely. Definitely something I will give my patients. I am more likely to lean towards paracetamol in these guys than I am to non-steroidals because essentially bad, if I'm seeing a C-section, it's probably pretty bad. So mum is probably not very cardiovascularly stable. So I'm going to be leaning more towards paracetamol anyway. And then again, the evidence is, we don't have a lot of evidence. But if you look at humans, for example, most C-sections get sent home with paracetamol for your analgesia. I can say that is absolutely what they send you home with, some paracetamol, and that's about it. And if you need to take some ibuprofen. So that tends to be what I do. So making sure you've got the local, utilizing what you have available to you, and yeah, one or other. If you're in doubt, lean towards paracetamol is absolutely fine. That tends to be what I do.
Wonderful. I think, Robyn, this was the last question that we had to discuss, and we actually made it to our normal 1.5 hours for this, with the questions included, which is great. We're very consistent with this. You've had a lot of positive feedback, just so you know, and people have really appreciated this session. I know I've really enjoyed it as well. So I want to thank you for doing it for us. Keep us posted on how things are going with your project as well.
Thank you.
And of course, I want to thank everyone who has joined the session and who has spent their time with us and trusted us to share some knowledge with you. We hope to see you on the next webinar. And I wish you all a good day, good night, good evening, wherever you guys are. Thank you so much for joining us one more time, everyone. Take care, everyone.
Thanks.